When someone suffers a heart attack at age 60, it looks like a sudden, isolated event. But that blockage is usually the final chapter of a biological sequence that takes 6 decades to unfold. To find the actual beginning of the sequence, you have to look before birth. In a landmark study called FELIC, researchers examined the aortas of fetuses and found fatty streaks already forming in the vessel walls. This was especially pronounced when the mother had high cholesterol during pregnancy, programming the offspring's vascular vulnerability before they took their first breath. By the teenage years, those streaks are almost universal. Autopsy data from the Bogalusa Heart Study and P-Day series showed that nearly 100% of young adults aged 15 to 34 had fatty streaks in their aortas. Even more striking, up to a third of them already had raised, solid plaques in their coronary arteries. Every single one of these early lesions is driven by the exact same mechanism, apolipoprotein B, or ApoB. ApoB is the single protein molecule that wraps around and carries cholesterol particles like LDL in your blood. If you want to count the exact number of plaque-causing particles floating in your system, you count the ApoB. The evidence points to a specific conclusion. Atherosclerosis is an active, progressive pediatric disease. The heart attacks and strokes we see in middle age are simply the mathematical result of how many ApoB particles a person has been exposed to over their entire life. This raises an obvious question. If severe plaques are actively growing inside our arteries during our 20s and 30s, why do we feel perfectly healthy? Why is there no chest pain, no shortness of breath? The answer is a biological compensation mechanism called outward remodeling, originally identified as the Glagoff phenomenon. As a plaque deposit starts to grow inside the arterial wall, the outer wall of the artery actually stretches outward. This keeps the central channel, where the blood flows, completely wide open and unobstructed. But the artery can only stretch so far. Once the plaque volume takes up about 40% of the space within that arterial wall, the outer wall reaches its physical limit. It stops expanding. The plaque is forced to spill inward, rapidly narrowing that central channel. Because of this remodeling trick, standard medical tests like resting angiograms or stress tests will routinely pass young and middle-aged adults as completely healthy. Their blood flow is perfectly normal, right up until that encroachment phase begins. A clean stress test or an absence of symptoms simply means your arteries have successfully compensated for the damage so far. The clinical silence holds right up until the structure finally fails. If ApoB particles are circulating through your entire bloodstream, you might expect plaque to coat the inside of your vascular system evenly, like rust inside a pipe. But it doesn't. Atherosclerosis is highly specific, targeting very particular spots while leaving others completely clean. The location of a plaque is dictated by fluid dynamics. In straight sections of an artery, blood flows smoothly in parallel lines. But at branching points and sharp curves, that flow becomes chaotic. The blood swirls and reverses direction, creating what researchers call disturbed flow. The delicate inner lining of your blood vessels, the endothelium, can physically feel this chaotic friction. In response, the cells undergo a structural change. Their tight junctions loosen up, creating tiny gaps that allow circulating ApoB particles to slip right out of the blood and get trapped inside the artery wall. Once the plaque starts growing, it needs oxygen. Thick arteries have their own microscopic blood supply called the vasa vasorum. When a plaque creates a hypoxic, oxygen-starved environment, these tiny vessels grow aggressively into the plaque itself. They act as direct conduits, pumping inflammatory immune cells straight into the core of the blockage. The location of a heart attack isn't random. It is the predictable intersection of the mechanical geometry of your blood vessels and the biological concentration of your ApoB. We know exactly how this highly focal damage translates to long-term decline because of massive, decades-long tracking studies. Projects like the Cardia and MESA cohorts began gathering data on young adults, tracking their vascular health year by year to watch how this subclinical decay quietly erodes the body's functional reserves. We see this play out in the smallest vessels first. The arteries supplying the reproductive organs are only 1 to 2 millimeters wide. A plaque burden that causes 0 symptoms in a large coronary artery will completely choke off these tiny vessels. Because of this artery size hypothesis, erectile dysfunction routinely precedes a clinical cardiac diagnosis by years. A similar decay happens in the brain. As plaques slowly restrict the large vessels in the neck, overall cerebral blood flow drops. This chronically reduced flow makes it harder for the brain to wash away toxic amyloid proteins, creating a direct biological link between systemic arterial decay and the onset of Alzheimer's and dementia. Women often experience a distinct version of this microvascular collapse. Instead of large, localized blockages, they frequently develop diffuse disease in the tiny capillaries of the heart muscle, a condition called inoca, or ischemia with no obstructive arteries. The main pipes look clear, but the microscopic network fails. Long before it causes a fatal event, atherosclerosis acts as a systemic, whole-body syndrome. It steals cognitive processing speed, limits exercise tolerance, and restricts sexual function, quietly degrading the quality of life while remaining officially silent. For decades, the medical consensus held that once plaque formed in an artery, it was permanent. You could try to slow it down, but you couldn't reverse the damage. Modern imaging has proven that assumption wrong. With intense reductions in ApoB and inflammation, plaque can shrink. The first major piece of evidence came from intensive lifestyle interventions. In the Lifestyle Heart Trial, researchers took patients with documented coronary disease and placed them on a strict whole-food plant-based diet alongside exercise and stress management. After a year, angiograms showed actual physical regression of the coronary blockages. This graph plots a patient's LDL cholesterol concentration on the horizontal axis against the volume of their arterial plaque on the vertical axis. Using tiny ultrasound cameras placed directly inside the arteries of thousands of trial patients, researchers found a clear threshold. When medication drives LDL cholesterol well below 70 milligrams per deciliter, the curve crosses the zero line. The plaque stops growing and begins to physically regress. Beyond simple shrinkage, the plaque's internal structure undergoes a vital transformation toward stability. As the ApoB particles are drained from the system, the dangerous liquid-filled core of a vulnerable plaque begins to drain as well. The thin, fragile membrane covering the blockage thickens into a dense, solid scar, drastically lowering the chance of it rupturing. Plaque regression is a biological reality. If you lower the particle concentration enough, the body's natural healing mechanisms can stabilize the vessel wall. To see what happens when that particle concentration stays low for an entire lifetime, we can look at the Tsimane people of the Bolivian Amazon. They live a highly active, foraging lifestyle and maintain average LDL levels around 90 milligrams per deciliter. When researchers scanned their hearts, they found that 65% of adults over age 75 had exactly zero coronary calcification. This brings us to the most accurate way to measure cardiovascular risk, the cholesterol years model. Much like calculating pack years for a smoker, your risk of an event is the mathematical total of your ApoB particle concentration multiplied by the number of years you've been exposed to it. This chart shows the cumulative exposure of those particles over a lifetime. For someone with average cholesterol, the area under the curve hits the red danger threshold by age 50. But for someone maintaining genetically or therapeutically low LDL from youth, the curve stays flat. They can reach 80 or 90 years old without ever hitting the threshold for clinical disease. The operational takeaway is direct. Measure your ApoB and your baseline vascular health early. Lower your particle burden through diet or medication, and sustain that control indefinitely to flatline your risk curve. Atherosclerosis begins in the womb and quietly steals our vitality for decades. But we now have the imaging tools to see it and the science to stop it. The goal of preventive cardiology is no longer to survive a heart attack. The goal is to eliminate atherosclerotic disease as a routine cause of human suffering.